Thank you, Peter. It's really a pleasure to be here today. As Peter mentioned, I'm a research faculty at the University of Minnesota and focus my research on treatment outcome studies of eating disorders, and also work for the training program at the Emily program, which is an eating disorder treatment program across the country. And I'm also a clinician in the community. So in talking about eating disorders today, I'll try to give you lenses on each of those perspectives, because there's obviously considerable overlap at different kinds of considerations that are made from each of those perspectives. So what I'm going to cover today, first of all, is give you an overview of eating disorders, what they are, specific criteria, clinical features, then talk about comorbidity with other psychiatric disorders, including substance use disorders, and then end with a focus on evidence. So in the recently revised DSM, the DSM-5, there are 5 types of eating disorders that are specified. The first is anorexia nervosa, and I'll talk about each of these in more detail. The second is bulimia nervosa. The third is binge eating disorder, which was just added to the DSM. And then there's 2 other categories, other specified, which include specific types of subthreshold conditions, and unspecified for people who don't meet criteria for the other conditions but still have eating disorder symptoms. So I'd like to talk about each of those in a little more detail. The first is anorexia nervosa. We typically see the peak onset at ages of 14 to 18, which usually corresponds with the onset of high school and the onset of college. This is traditionally what we've seen as far as age of onset. But what's interesting as we understand this better from community, not just clinical samples, is we'll see anorexia onset at all ages. So a lot of times people think that anorexia nervosa is a condition that only adolescents and young adult women have, but we actually see it in males as well, although 50% or 90% of the people with eating disorders with anorexia are female. And we do see it later ages of onset as well. And the prevalence rate, if you define anorexia strictly, which I'll show you in just a minute, if you with strict definitions, we see prevalence rates at less than 1%. Now, if you end up broadening the criteria as far as the weight or some of the psychological features, you'll see a slightly higher rate. But it's important to keep this in mind, I think, when you start to see information about the epidemic of eating disorders. When we use strict definitions, we're seeing relatively low prevalence rates. Now, here are the criteria for anorexia nervosa. The first is the restriction of energy intake relative to requirements leading to significantly low body weight. And this is in the context of age, sex, developmental trajectory, and physical health. And what this usually means is that people are under-eating compared to what they need to be eating for their energy expenditure. But sometimes it means that people are eating regular amounts, but their exercise level is so high that they end up underweight. The second criterion is the intense fear of gaining weight or becoming fat. And for some of our patients, this means they're afraid of gaining any kind of weight. For others, it's a fear of obesity. The other piece we see for some, especially for people who've been ill for a number of years, is they may not really worry about this as much anymore, but they're still acting in a way to prevent weight gain. And you can use that within the criterion as well. The third is a disturbance in the way in which one's weight or shape is experienced, or the lack of recognition of the seriousness of current low body weight. And this can involve the overestimation of size and shape, or overvaluation of shape and weight within self-evaluation, which I'll talk about a little bit later. And then finally, and this is important, especially in understanding how anorexia nervosa differs from bulimia nervosa, you have 2 subtypes. The first is the restricting subtype, and these are individuals who typically restrict their food intake and exercise a fair bit typically, but do not engage in binge eating and purging. But we also have a binge eating and purging group, and these are individuals who are underweight. They're typically restricting and often exercising, but they're also engaging in binge eating and purging behavior. And the reason this is important is sometimes people think that that is just a feature of bulimia nervosa, but in fact it's a feature of binge eating and purging within anorexia as well. So turning to bulimia nervosa, we see prevalence rates a little bit higher, 0.5 to 3% of the population, again, depending on how strictly you're defining it. Once again, we primarily see females with bulimia, although in community samples, we certainly do see males in some of our clinical samples as well. And we know from our males with eating disorders, a lot of times they feel tremendous stigma in seeking treatment. So I think sometimes we underestimate the prevalence. Some of the other features of bulimia nervosa is that weight is usually in the normal range. We'll sometimes see people on the lower weight side who don't quite have anorexia, and we'll certainly see a smaller percentage of people who are overweight or obese, but the majority of our patients with bulimia are in the normal weight range. But one very important piece in all this, I started working in this field in 1985, and at that point we really thought that you had strict characterizations of eating disorders. You had people with anorexia or people with bulimia, and there were certain types. And what we've seen through the data through the last few decades is this really isn't the case. When you follow people over the course of time, you often see people switching into different diagnostic categories. So for example, we see a pretty large percentage, 20 to 40% of people with anorexia, if you follow them over time, they'll end up with bulimia nervosa. And some of these are people who were binging and purging when they were at a lower weight. Others may have been restricting and then end up binging and purging within the normal weight range. And then the other piece of this, and this is interesting, I'll describe the criteria in a minute, is that bulimia nervosa tends to be thought of as a condition that's characterized by binge eating and compensatory behaviors, but we know that this group of patients actually engage in a lot of dietary restrictions. So they may not be underweight, but if you look at their eating patterns, a lot of times they are restricting their food intake and trying to follow very strict rules as far as what and when they're eating. So one of the areas of greatest controversy within the diagnostic criteria for bulimia nervosa is the definition of binge eating. What the DSM requires, and this may end up changing and may in fact even be changing for the ICD-11, is two features. First is that the amount of food consumed during the binge eating episode is something that you would definitely consider a large amount of food. And this is an important consideration because a lot of our patients will say, you know, I planned to have a sandwich, I didn't plan to put mayonnaise on it, and I did, so I consider it a binge. We would consider this an episode of a subjective bulimic experience where the amount of food isn't large, but the person felt like they'd overeaten with a sense of loss of control. But for the diagnostic criteria for bulimia, it needs to be an amount of food that's definitely large. And then the second criterion is a sense of lack of control or loss of control over eating during the episode. So this is sometimes a feeling that you can't stop yourself once you start eating, or if the food is there, you can't resist it, or a feeling of being driven or compelled to eat in the context of the overeating episode. And one of the ways these criteria got developed was based on some of the early feeding lab studies. At first we were trying to, in the 80s, trying to collect clinical data from people with bulimia to determine what these binge eating episodes look like. And when we actually had people in the feeding lab, we give them privacy and access to whatever food they wanted. What you saw is across various labs, very similar kinds of average caloric intake during binge eating episodes. So typically we're seeing 3,000 to 5,000 calories at once. And more recent studies have replicated this in community samples as well. So one of the reasons these criteria got set was based on these early studies showing that there really typically is a large amount of food consumed. But we know that people with eating disorders may also have episodes in which they consider it a large amount of food, but as clinical raters we wouldn't. So the binge eating episodes are accompanied by recurrent inappropriate compensatory behaviors to prevent weight gain. These typically include self-induced vomiting, and if you look at the frequency of compensatory behaviors, this is by far the most common. But we'll also see misuse of laxatives, diuretics, or other types of medications. For example, for people with diabetes, they may manipulate their insulin. We'll also see fasting or excessive exercise with very high, very intense levels of exercise. Now, the DSM-5 recently changed the frequency requirement, so to be diagnosed with bulimia, you need to have binge eating and this type of inappropriate compensatory behavior once a week for 3 months. So we'll also see people with less frequent episodes, they'll be given a different type of diagnosis, and we'll typically clinically see much higher rates, but in order to be given the diagnosis, you need that level of frequency. And then another concept that I'll talk about later in the context of treatment is this idea of self-evaluation. And what this is essentially the extent to which someone's evaluating their sense of worth as a person by the extent to which they value or see positively or negatively their body shape and weight. So what that means is we know for most people, especially women in Western society, they'll see their weight and shape or their appearance as an aspect of how they'd evaluate themselves as a person. But oftentimes for our patients with eating disorders, their weight or shape is the most important thing. So for example, if they found that they've gained weight, they believe that they're worthless as a person. So that's another criterion. And then finally, the last criterion is a point I made earlier. that the bulimia nervosa has to occur outside the anorexia nervosa. So if you have someone with binge eating and compensatory behavior who is meeting criteria for anorexia and they're significantly underweight, you're going to diagnose them as anorexia nervosa, binge eating, and purging type. And then finally, binge eating disorder, and this is a more recently recognized disorder, although one that's been studied for several decades now. This is a disorder that's characterized by binge eating episodes without compensatory behaviors. Now, one of the greatest misnomers, I think, is a sense that if someone is overweight or obese, they must be binge eating. But by our clinical definition of binge eating, it's actually a pretty small percent of the populations, about 3% among people who are obese, maybe 8 to 10%. And if you look at the group seeking treatment for obesity, you'll see binge eating disorder in about 10 to 30%. So what that means is among people who are obese, obviously there may have been or may be a mismatch between energy expenditure and energy intake, but they don't necessarily have binge eating episodes where they're consuming a large amount of food with that sense of loss of control. And binge eating disorder is the one where we see still more females relative to males as far as the prevalence, but we see it more commonly in males. So it's females are 1.5 times more likely to have binge eating disorder than male. And as I mentioned, the majority of people with it have comorbid obesity. We typically see onset in late adolescence. And what's interesting about binge eating disorder, some people report the onset in childhood. Others seem to have a period of dieting first in the context of weight gain, and then that dieting can make the binge eating worse. So the criteria for the DSM require binge eating episodes with associated conditions. And the reason these were put in, there was a lot of concern about putting binge eating into the diagnostic criteria with something that could potentially be seen as a normative experience. So in order to be given the diagnosis, you have to have a certain number of features, including eating more rapidly, eating until you're uncomfortably full, things related to feeling embarrassed or depressed afterwards, along with marked distress. So, for example, if you're at a Super Bowl party eating a large amount of food, that's not something that's going to be classified as binge eating within the context of binge eating disorder. And then it also occurs for the diagnosis once a week for 3 months at minimum. So one of the things that I've experienced as an eating disorder clinician and researcher is, especially early on as eating disorders were really gaining a better understanding in the course of the 80s and 90s, is that there tended to be a misunderstanding around the nature of these kinds of disorders. There was a sense that maybe these were sort of transient, almost normative conditions that females went through in the context of trying to meet a sociocultural ideal. And things really changed for us in the field in the 1990s when two things emerged. First of all, it became clear from the genetic research that there's a very strong heritability component to eating disorders. What exactly is herited, we don't know what that risk is, but you see very high levels of heritability as demonstrated by twin studies. The other piece of data that made a huge difference in an understanding of the seriousness of these disorders were the publication of the mortality and suicide rates by Harris and Barraclough in 1998. Because what you can see is if you look at mortality rates across psychiatric conditions, you see compared to alcohol abuse, schizophrenia, major depression, and bipolar disorder, rates for all-cause mortality, so this could be a medically related death or suicide, whatever the cause, were the only rates higher were for opiate abuse. So this was very significant. Even more so is when you look at suicide rates, it was highest for eating disorders. So higher than major depression, higher for than schizophrenia. And I think this had a really significant impact on understanding the seriousness of this disorder. It's one of the things we emphasize most in training our clinicians and training our students that suicide is a very significant risk among this population. And this actually overlaps, I think, with one of the biggest challenges, and I think one of the things that makes eating disorders difficult to treat but also very interesting to try to understand, and that's the high rate of comorbidity, and I'll show you these rates in a minute. But when I started in this field in the 1980s, there was questions of whether eating disorders were actually a form of depression, and it turns out what we really understand clinically is they are distinct, but we see very high rates of mood disorders and eating disorders. And there's been a long-standing debate of, do eating disorders cause depression to be worse? Does depression make eating disorders disorders worse. And it looks like it's a bidirectional relationship in which both conditions can make the others worse. We also know for some people they'll have their eating disorder first and then develop depression and vice versa. So the complexity rate's high, but we do know the rates of comorbidity are very significant. This was a comorbidity study conducted by Jim Hudson, and what he found, if you look at any mood disorders, for anorexia, bulimia, and binge eating disorder, you're seeing rates of 40 to 70%. And I will say this was a community sample, and compared to a lot of what we've seen in inpatient or clinical studies, these rates are actually lower. We often see higher rates of lifetime mood disorders in anorexia. But nonetheless, you're seeing very high rates, especially of depression, although we see some bipolar and dysthymia as well. And similar findings for anxiety disorders. So if you look at this bottom row here, for any anxiety disorder, again, you're seeing rates of 40 to 80%. And what you're often seeing are different types of social anxiety and specific phobia. You're also seeing relatively high rates of PTSD, and we know that trauma histories are very common among people with eating disorders. And then I think especially important in this context, within this audience, is rates of alcohol and drug use problems. And what's interesting in this study, I think, is that the findings were pretty robust with what we've seen really, I think, through the decades. They typically see about 15 to 30% of individuals presenting with an eating disorder with a lifetime history of alcohol or drug use problems. And this, I think, it doesn't necessarily mean they're presenting at the time with these kinds of symptoms, but if you look at their history, you typically see this. And one of the things that's also interesting is when you look at lifetime rates within different types of anorexia, the restricting group versus the binge eating and purging group. This is one example. You typically see higher rates in people who are currently binge eating and purging. So we know that that group is more likely to have substance use disorders currently or in their past. And there are a few considerations that I think are especially important in the context of eating disorders and substance use disorders. And some of these issues come out in the context of assessments. And if you look at a lot of standard assessments for eating disorders and for alcohol and drug use problems, you'll see sort of a threshold of what level will be considered problematic. And what you see in our nutritionally compromised patients is a lot of times what would be considered excessive in the general population, say 5 drinks, which some measures use as a threshold, is much too high for our patients who could become very intoxicated at much lower rates than this. So one consideration we always think about is not looking just at the amount that people are drinking, but how it's actively affecting them. As you can imagine, we see a lot of diet pill and stimulant use in our populations, and it's always been assumed that this is in the context of the pursuit of weight loss, but we also see it for mood enhancement as well. But it's just something to keep in mind that we see a very high rate of stimulant use and misuse within this population, both in the context of mood enhancement or in the context of ADHD kinds of medications being misused, and for the pursuit of weight and shape change. And then finally, another important consideration with this group of people with eating disorders, with substance use disorders, is that there's a subgroup that have been characterized by a number of people, including Hubert Lacey and Tricia Myers, as multi-impulsive. And this is a group that typically has eating disorders along with other type of impulsive behaviors. So shoplifting, multiple types of purging behavior, so not just purging with vomiting, impulsive sexual behavior, self-injury, and substance use. So oftentimes what you'll see among people with eating disorders, especially bulimia, with these types of substance use patterns is multi-impulsivity. And then finally, in considering comorbidity and eating disorders, I think one of the most important considerations is that most of our patients have multiple disorders. So first of all, I think, again, this is from the Hudson data, you see very high rates of any comorbid diagnosis. So 95% in bulimia, over half in anorexia, and about 79% in binge eating disorder. So it means that most of the time when we're seeing someone clinically, we're seeing another disorder. But one of the things that's really striking here is look at the percentage that have 3 or more diagnoses. And so oftentimes what we're seeing clinically is someone with a mood disorder and an anxiety disorder and a history of substance use. This is really not unusual at all. So you can see here for 3 or more diagnoses, we're seeing from 30 to 65%. Now, one of the things that's most difficult in diagnosing and treating comorbidity and eating disorders is that much of these symptoms can be caused or at least exacerbated by malnourishment and semi-starvation. We know from the semi-starvation studies that were conducted here in the 1950s or in the 1940s with conscientious objectors by Ansel Keys, found that if you put people on a semi-starvation diet, you do see symptoms of depression, anxiety. So sometimes when we see someone, we don't know if they have a primary mood or anxiety disorder or if what we're seeing is secondary to their semi-starvation. And this is true in people with at various types of body mass index levels. We can see malnourishment regardless of someone's actual weight status. So what we typically do in treating comorbidity, probably with the exceptions of substance use disorders, is we'll treat the eating disorder first and see if normalizing the eating and the weight can lead to improvement in depression and anxiety, but that's not often the case. And we also see very high rates of personality disorders as well, especially cluster B symptoms. So I want to switch gears and talk a bit about treatments, specifically which treatments are evidence-based. And by evidence-based, what we're saying is that it's a treatment that's been studied in a randomized trial within some sort of research setting and found to do well compared to a control group or another sort of clinical treatment. This is not an exclusive list. In fact, if you went to most community programs, you see a much wider base of treatments than this list for reasons that I'll talk about in just a minute. But these are the ones that have actually been studied. And one of the reasons I think it's important within eating disorders to keep in mind that we probably have broader treatments is that we often see people with eating disorders that don't meet full criteria. And most of these studies have been conducted with people with anorexia and bulimia and binge eating disorder. So sometimes I think if you're working in a clinical setting, you're going to be using a broader based set of treatments than these. But nonetheless, these are the ones that have been studied. Cognitive behavioral therapy, which I'll talk about each of these in a minute, interpersonal therapy, family-based treatment, and dialectical behavior therapy, which I won't talk about much today, but DBT is just beginning to have a database supporting it within eating disorders, and antidepressant medications, which I won't talk about, but I can in the questions if people are interested in that. So here are the considerations. First of all, one of the things that we typically do, the standard practice within clinical care for eating disorders, is assess someone's weight and medical status to see if they need to be weight restored if they're significantly underweight, or if they're medically unstable and need medical stabilization, which typically occurs in an inpatient setting, not always, but often. We also use a lot of residential and intensive treatments. This is, again, standard care. And the problem with our research data is that most of these studies have been conducted on an outpatient population. So it means what we're doing in our inpatient, residential, and intensive settings is trying to adapt what we've learned from outpatient settings into these different types of settings. So it's tricky because we know that some of these principles may work well with people on an outpatient basis, but may or may not work well in more intensive settings. And one of the reasons these haven't been done is they're very expensive to do. To do a randomized trial in an intensive setting is very difficult. Fortunately, there are current studies underway in these kinds of settings to see what works, at least from a naturalistic perspective, and that should give us more data. A second point, and I'll show you data in a few minutes, is that our good outcomes with eating disorders are limited. And I think that doesn't mean they're bad. I mean, I think we've made a lot of strides. We're very good at helping people improve. We help them get to a healthier weight if they have trouble with anorexia. We help them binge and purge less if they have trouble with bulimia. But we have trouble getting people fully recovered. So they may go from binging and purging, 5 times a day to once every week, which is fantastic. It looks great statistically, but we know that that group that still has lingering symptoms is at most greatest risk of relapse. So I think we need to do a better job of being able to get people in full remission. And then another problem is we have high dropout rates. Now, I think that we could certainly, and what you typically hear in the clinical and research literature, is that people with eating disorders often have very mixed feelings about being in treatment. Sometimes they really don't want to gain weight, or they're scared of changing their behavior, and this is very much true clinically. But I think sometimes our treatments may not be a good match, and it's something we need to work on to make sure our treatments are more accessible. And we also see very significant relapse rates, typically 20% across different types of disorders, so we need to find ways of making our treatments more sustaining. And then finally, back to the previous point, I think we do a better job now than we did earlier on in these treatment outcome studies of including people with comorbidity. Typically, we'll include people with depression and anxiety and some personality disorder symptoms. But oftentimes, people with more severe psychopathology are excluded. So for people with active substance use problems, they're often excluded from treatment, or someone who's really acutely suicidal. And what that means is the clients and the patients that we're often seeing in clinical settings may or may not be included in our research studies. So sometimes we're trying to extrapolate into our clinical settings what may or may not be representative within our research trials. So from there, I want to talk about these very specific types of disorder and the treatments that we use for them. The first is cognitive behavioral therapy. So this is probably a type of psychotherapy that most of you are familiar with. It was developed for the treatment of depression, has been adapted for all types of conditions, including anxiety and substance use, as well as eating disorders. And the idea here is to target the thoughts and behaviors that cause and especially maintain eating disorders. So we know that there are a lot of factors, biological, genetic, psychological, and sociocultural, that put people at risk of eating disorders, but we know that a lot of times it's other types of factors that maintain these disorders once they start. So these are really targeted within this type of treatment, and especially I think that one of the things that's been most important is the development of an enhanced type of cognitive behavioral therapy, CBTE, by the Oxford group, that can be used for all different types of eating disorders. So this is includes the treatment manual that we used for a number of years, the 1993 version, and then this was published in 2008, which has the more extended version that we've typically used. So what I'm typically doing if I'm doing CBTE with someone with an eating disorder, it does not quite look like this, because what we do at the first session is sit down and say, what kinds of things seem to be causing and maintaining your symptoms? And then this is what it'll typically turn out to be, and I'll talk you through it in a minute. But if I'm using this clinically, I have a blank piece of paper, I'm sitting with the patient, and we're drawing this out together. So what typically happens, people will say, well, you know, I engage in binge eating, and this then relates to my my vomiting, because I'll vomit because I've engaged in binge eating and I'm worried about gaining weight, or I'll use laxatives. And then because I've decided to do that, that will then make my binge eating worse. So you see these arrows going in both directions. And then sometimes this also relates to dieting and restricting, or being at a low weight, depending if someone is, because we know if someone's underweight or someone's restricting, even if they're just having rules and they're not following them successfully, this can still be a good trigger of binge eating, which I'll talk about in a minute. And then we also know that underlying this is a really strong concern about shape and weight, which oftentimes drives this type of dieting behavior and leads to problems with compensatory behavior. And then the binge eating, of course, makes people scared of gaining weight. So we also see events and mood changes that can be related as well. So what we want to do at the end of session 1 is have this diagram, and again, you know, when we're using it clinically, it's usually much messier, and it's helpful to people because they can see that the reason they're trapped in this behavior is you have all of these kinds of factors that are maintaining these symptoms. So what we're doing in cognitive behavioral therapy is taking each of these boxes systematically. The other analogy is a house of cards. You really want to kind of pull down the whole house of cards of things that are sustaining it. So one of the other things we do at the first session is introduce self-monitoring. And what we ask people to do is write down what they're eating, when they're eating, and the stars for anything that feels excessive to them. So this may be a small amount of food or a large amount of food, whatever they consider a binge or an overeating episode. And then we have them write down VLE, and this is vomiting, laxative, or exercise, any compensatory behaviors. So for this person, this is someone from one of our early bulimia studies. You can see at 8 o'clock she had a bagel, described this as breakfast at home. Then at 10 o'clock, she had 8 donuts. She thought this was a binge and vomited, and she was at work upset about a meeting. So then she'll bring this into session 2. I'll have that diagram that we did at session 1, and I'll say, oh my gosh, it's just like you told me. If you're upset about things, sometimes that'll trigger it, and then once you end up feeling like you've overeaten, that will then induce vomiting for you. So we're working together in going between the food records and the diagram, understanding how these patterns work. We also have people start to weigh themselves weekly, and we'll weigh them in sessions, because typically what we see with our patients is they're either weighing themselves all the time or avoiding it completely. And we want them to get desensitized to it and also get used to this idea that their weight's going to fluctuate. So we really want them to start doing this, but not weighing themselves so much that they get sort of tricked by too much information. One of the most powerful pieces of information that we give to people who are doing any sort of purging is the ineffectiveness of this strategy for weight control. One of the things we used to say in the early 80s was, you know, if you have bulimia, you may end up gaining weight in the context of getting well. But what we saw after decades of data is that people tended to stay the same weight. And as it turned out from feeding lab studies that were done at University of Pittsburgh, they had people binge and then purge, and then they did an analysis of the vomit and the calorie content. They found that people were retaining 30 to 50% of what they're eating, regardless of how much they purge. And what that tells us is that people a lot of times will engage in purging because they think, okay, I'm getting rid of all of this, when in fact they're retaining this. And we want people to understand that they can actually be eating more food in a planned way to prevent binges, and they're going to stay about the same weight because the purging really isn't getting rid of the food the way they think it does. And we also help them understand that laxatives will affect their fluid intake but not actually get rid of any actual food in the context of the diarrhea. We also talk about the different types of dieting behavior. Typically, all types of people with eating disorders will go long periods of time without eating. They'll avoid certain types of food, and they'll restrict the amount of food they're eating. And they tend to follow very strict rules. So CBT really targets these rules. People tend to blame themselves, say, it's my fault because I couldn't follow these strict rules. And we tell them, what we know from data from around the world is if people try to follow these strict rules, eventually they're going to binge eat. So we need you to be less strict with yourself and get into a regular pattern of planned eating, and this will prevent the binge eating. So then we help people understand what their different cues of binge eating are, and we have them come up with a list of things they can do if they're feeling like binging, or if they're feeling like purging, or engaging in exercise, or whatever it is. And this can be things like listening to music or texting a friend. But we want them to be really specific, not just listening to music, but what type of music, which friend will they text. And then something that we've actually taken from the substance use treatment is this idea of urge surfing, because much as our clients with substance use struggle with, they feel like with the eating disorder symptoms, if they don't binge, if they don't purge, if they don't do it, they feel like they're just going to explode. But we help them understand that urges are like a wave. If you can ride them out, they will come down. And then this works in the process of extinction, which is part of what we know is important. We also help them identify the rules that they may have and have them start to break them. So, for example, if they say, I must not eat past 7, we'll have them eat at 7:01 or 7:03 so that they can really start to be more comfortable with this. And we'll also have them target foods that they're avoiding so that they can eat them. In the third phase of treatment, we spent a lot of time on this shape and weight issue, because one of the things we find is that our patients are often checking their shape and weight all the time. They're pinching, looking in the mirror, and doing these kinds of things. We'll send them off with self-monitoring to see how often they're checking their shape, and usually they come back realizing they're doing it hundreds of times a day. They're sitting in class and checking on their thighs, or they're in the gym and looking in the mirror. And what we want to do is have them stop doing this, because this type of vigilance seems to make body image much, much worse. It makes mood worse, and it makes eating disorder symptoms worse. And the analogy that we use is the spider phobia. So what we find is if someone's afraid of spiders, the rest of us will see, this small spider running across the floor. But if you're afraid of spiders, that same spider to someone who's phobic looks like a huge tarantula. And that's what happens with our patients with eating disorders. They're terrified of gaining weight, and they tend to be very preoccupied with certain body parts, and they're staring at their thighs over and over and over again, and it starts to make their legs look bigger. So we want them to not stare at themselves all the time, not be so vigilant, and be aware of the fact that this kind of distortion can make it worse. So that's one of the things we'll focus on. We'll also talk about the self-evaluation piece, because they tend, as we talked about earlier, to be very focused on aspects of shape and weight and really defining who they are as a person. And we call, the Oxford group calls this the self-esteem pie. So we'll work with people on spending less time focusing on their shape and weight, really talking about how well this works for them, but also spending time doing things in their neglected domain. So friends, hobbies they may be neglecting, because the sheer act of focus and time can bring down the shape and weight of some of these other pieces get bigger. So that's one of the things we'll do as well. And in the final phase of CBTE, we'll focus on the lapse versus the relapse. Again, something that's probably familiar if you work in the substance use area, helping people understand they may have symptoms of eating disorders. They may, skip a meal or they may binge, but that doesn't mean they're relapsing. They can use that information to get back on track, and we'll have people come up with a written maintenance plan to help them with that. Now, as you can tell in CBT, we spend a lot of time focusing on very detailed patterns of eating and thoughts about weight and shape. Interpersonal therapy is very different. This was a treatment that was developed for depression and then has been adapted to various kinds of conditions, including bulimia and binge eating disorder. And what you see in IPT is you're really focusing on changing relationships in the here and now. And the idea is that relationships can make eating disorder symptoms worse because when people are upset, they're more likely to engage in them. But eating disorders also tend to make relationships worse because people tend to get more withdrawn. So what you tend to do as a therapist when I'm doing IPT, I'm very different in my focus than when I'm doing CBT, because we do an initial phase where we're trying to figure out what the main interpersonal problems are, and then we really shift to more almost traditional supportive insight-oriented therapy to change those kinds of current patterns. And this can include grief. This is typically the death of a loved one, and it may have occurred a long time ago. Interpersonal deficits for people who are socially isolated or shy. Role transitions are very common in eating disorders, people who are starting school, finishing school, empty nested, and then interpersonal role disputes, which is typically like conflict related within a marriage or a dating relationship or fighting with parents or coworkers. So we'll identify one or two of these, and then in the next stage we'll really have the patient focus on making changes in this. We're not typically talking about eating or weight and shape. We're really talking about, all right, so what did you do this week around addressing issues with your dad or whatever the relationship problem is. And then in the final phase of treatment, we'll really try to kind of work on looking in the future, what might some relationship problems be, and also help people understand that their relationships are likely to continue to improve in their eating disorder symptoms as well. And the reason we know this has actually been replicated 2 other times. If you compare in randomized trials CBT, cognitive behavioral therapy, versus IPT, what you typically see, this is for bulimia nervosa, this is percentage of people free from binge eating and purging, so the higher the better. And what you tend to see is at the end of treatment, the group in CBT, you have a higher rate of people in remission. But look what happens over the course of recovery, over the course of time. You see some people start to relapse in CBT, but you see more and more improvement in IPT. And what that suggests to us is that IPT seems to have sort of this enduring effect after the end of treatment. So what this means for me clinically, if I'm in my practice and I have someone coming in, I can really in good conscience offer them CBT or IPT for bulimia, knowing that both really have a lot to data to support them. And the same is true for binge eating disorder. Here you don't really see a lag effect. This has, again, been replicated. This is a percentage of people binge free. And you can see CBT and IPT really look about the same. They're both very effective in helping people in remission. So we know that these 2 are probably the most widely studied in outpatient therapy for eating disorders. Now, I would say in the last couple of decades, one of the most exciting advances in the field is family-based treatment, and it's called family-based treatment rather than family therapy because it has a very different focus from the types of more traditional family therapy we used to do back in the 80s and 90s. In those types of traditional family treatments, we would have all the families meet together, and we would oftentimes sort of separate the child with the eating disorder from the parents to try to create more autonomy. And the group at the Maudsley Hospital in England looked at this and said, you know what, I think this is backwards. I think we need to be working with the families and empower the families to help them help their children and teenagers. So it really took a different perspective on the role of parents, and it takes the position that it's the therapist's role to facilitate the parents' power in refeeding their child or adolescent. So and I'll describe the treatment in a minute, but the data really support this. It looks like it works extremely well for children and adolescents and potentially even young adults. There are studies being done now with anorexia and bulimia nervosa to really have the parents or a significant other work with the person to help them eat more or change their eating patterns. There's a couple of caveats here. One is it looks like it works better with younger patients, which isn't surprising, I think, because you're empowering the parents. And I'll tell you, a lot of times the teenagers who come in for this type of treatment just hate it at first, but then as the family's working together, it's very helpful for them. But it also seems to work better for people who've been ill for a shorter duration. So we know that it's really helpful with adolescents and kids to get them into treatment early so that we can help them and help their families work together to get them out of this pattern. So what you're typically doing in phase 1 is meeting with the family, charging them with this idea of refeeding. And for some of these families, this means the parent is taking a leave of absence from work, they're going to school and having lunch with their child, they're changing all of their family routines, they're having their children not do after-school sports. And then for session 2, the family brings a meal to eat in the session, and the therapist then coaches the parents of how to get the child to eat one more bite. You also work on some of the family patterns, especially reducing family criticism, and you're trying to get sibling support for this. So you end up with the parents taking a very strong and active role in this until you can see the child or adolescent eating more independently. Then you're really trying to shift the focus away from the parents, because what you typically see in families with eating disorders is that there's such a focus and it's a way of communication. So you really want to shift the family away from that and work toward more independence and direct communication outside of shape and weight. And I think one of the most elegant aspects of family-based therapy is they use this narrative approach where instead of the blame around the person with the eating disorder, not eating breakfast or whatever it is, the family unites against the eating disorder. And the eating disorder is almost talked about as like a third person. And I think that has found to be very effective. So before I finish, I just want to say a few words about course. One, I think it's an important piece of this, and this isn't always the case for people with anorexia who are low weight and recognized as needing treatment. But what we know from a number of data sets is that the average duration is about 6 years between the onset of bulimic symptoms, and this could be within any context of a type of eating disorder, and the decision to seek treatment. And I think this is one of our biggest charges within the field is how do we identify symptoms earlier? How do we get treatment to people who need it? And this may be in the form of traditional therapy, or it may be more web-based, more technology-delivered treatments that we know can be very helpful for some people. Because if you think about it, if you have the onset of symptoms at age 14, that means you're not seeking treatment until age 20. And this has huge developmental impact. So that's one problem. A second problem we know, at least within Western communities, that the majority of people with individuals with eating disorders never end up seeking treatment. So most of the estimates suggest that we're probably in our clinical programs treating maybe 20%, but more likely 10% of people in communities with eating disorders. So it means the majority of our patients who are struggling with eating disorders are never seeking treatment. And I think there's a number of barriers. One, obviously, is still stigma around mental health. There's a lot of cost barriers around access to treatment. Eating disorder tends to be pretty specialized treatment, and a lot of people in rural settings don't necessarily have access to this. And then, obviously, some of this as well is people saying, maybe I struggle with this, but I don't really want to seek treatment. But I think that this is something that's going to be very important for us to do. One of the things I hear a lot is that kind of this myth that people kind of come in and out of eating disorder symptoms, and we really know that's not true. These are very serious conditions, and it's not something you want to just kind of wait and see people, to wait and see if they can recover on their own. But the other thing I hear is once you have an eating disorder, you'll always have an eating disorder. And our long-term data really don't suggest that either. It looks like people do tend to have 30 to 50%, if you're following them over 10 or 20 years, will have symptoms, but they may not be as severe. But again, what that shows us is I think we do a good job of getting a lot of people in remission, but there are a number of lingering symptoms. And then finally, I think one of the things that's most interesting but challenging about eating disorders is they tend to move across different diagnostic categories. So you'll have people who start with one type of eating disorder and then over time will end up shifting into another type. And that means that I think our treatments have to be really targeting this kind of evolution in symptoms and trying to really make sure that we're really targeting various aspects of it rather than just the behavior itself, recognizing that some of these are risk factors for recurrence. So finally, I'll finish up, and then we'll. I think people may have questions that they have sent in. I just want to make a few final points. The eating disorders are characterized by complex psychological, behavioral, and physical, and I would include within that neurobiological features. I think this is an extremely exciting time within psychopathology because we've advanced within neuroscience where we're starting to be able to map on behavior with neurobiology that we're understanding through neuroimaging and other sorts of measures. And so I think we're going to have a much better understanding not just of what behavior symptoms look like or maybe underlying neurobehavioral risk factors, but what this looks like as far as actually mapping these behaviors onto specific kinds of for example, neuroimaging, circuitry measures, and this kind of thing. So I think we're going to be able to target these better within treatment as we're developing those better. The second point, obviously, eating disorders are associated with a lot of psychiatric comorbidity, including mood, anxiety, and substance use disorders, which I think is complicated as far as our understanding risk factors and treatment. Mortality and particularly suicide risk is very significant within these disorders. And finally, evidence-based treatments are promising, but novel and innovative treatments are needed. And I would say both in traditional medical, clinical, psychological settings, but also in technology-based and more sort of novel and innovative delivery capacities so that we can be reaching more people. So with that, I'll stop and take questions for a few minutes in the room, and then are there some that are being written in here?
Yeah, I'll give you one online and to just repeat it. So
yeah, I will. Okay.
Okay. So how long does a craving or urge last?
Oh, that's a really good question. So the question is, how long does a craving or urge last? So first of all, I'll tell you, we don't have good data around that. And interestingly, we're starting to collect that now. One of the things that our collaborative group does with our colleagues at University of North Dakota is what's called ecological momentary assessment. So we have people use their smartphones, and we'll be set up a program so that they're being paged throughout the day to record what they're thinking, what they're feeling, what their behaviors look like. And this gives us a huge amount of data. We'll typically do this for a 2-week period of time. And it allows us to really understand what patterns look like, how they overlap with behaviors and mood. But one of the things our group is very interested in is this idea of urges and cravings. So what I can tell you, what we see clinically is that most people, if they can wait out their urges and cravings within the hour, the intensity of it tends to come down. It may not go away. But what we'll see is most problematic for our patients is even if their urge to binge or purge or restrict comes down, we're finding very enduring preoccupations around weight and shape. So the relationship between those two things, because it's sometimes feeling fat, if you will, which is really common among our patients, is linked with that urge. So I would say that we can see urges around direct symptom behavior will probably come down within an hour or two, but some of the things that trigger those urges can be much more enduring. Yeah, go ahead.
Yes, how do you advise a family to have a child take one more bite?
That's a really good question. So this is the hardest part about family-based treatment. The question was, how do you advise the family to help the child take one more bite? So there's a lot of different strategies and I should say I don't do family-based treatment myself, but my colleagues who do. A lot of it is around providing support, helping really break it down into one very small thing. One of the things that is most helpful is to help parents shift toward blaming, negative threats, because we know that tends to make it worse. So an encouragement of taking one more bite is also, I think, can be done through using that narrative approach, saying, we know you're really struggling with the eating disorder right now, but I think that you have the power to really show that you can really have power over the eating disorder by just taking one more bite here. And then a lot of encouragement, a lot of support. It's hard to do, but it really can be done well. And I think part of why it works, honestly, is you're in this artificial situation and you have the therapist there who's being a coach and everyone's watching. But what happens in that artificial environment is it's almost like kindling that starts them so that they can take it from there. Really good question. Are there others that are being written in?
Yeah, here's one that says, I'm having difficulty finding treatment for individuals who have reached normal weight, who are even a bit overweight, but are still reporting psychological symptoms associated with their past eating disorder, even though they are currently engaging in this sort of behaviors.
Yeah.
Maybe not encouraging. No. Anyway, any suggestions?
Oh, I really appreciate this question. I'm not sure I can say it as eloquently as you typed it in. but it's a really significant problem. The question is about people who really are at a healthy weight or maybe a little bit overweight. Their behaviors are much improved. Maybe they're not binging and purging, but they still have a lot of the psychological features. They're probably preoccupied with eating, preoccupied with weight and shape. They may be avoiding situations because they're self-conscious about their appearance or eating. And what's interesting is a number of people in my clinical practice meet this description exactly, because they don't meet the full criteria so that they wouldn't enroll in sort of a more traditional comprehensive eating disorder program, because, you know, when they're evaluated, they're like, well, look, your binging behavior is a lot better. But we know, and in fact, one of the questions is how you draw that line between what is an eating disorder case and what's not an eating disorder case, especially when you're doing work within the community. And the group at Oxford argues, and I agree with them, that it is the psychological features that in some ways are the most disabling. If you're sitting in class and all you can think about is the donut you ate for breakfast this morning, it's really hard to concentrate. So I think there's a few options. First of all, what it probably means is looking for a clinician in the community rather than an eating disorder program. Although I will say a lot of eating disorder programs have groups, especially for people who are in recovery, as they describe it, who are behaviorally improved but may still be struggling. So I'd look at probably groups within eating disorder programs, clinicians in the community who may not be affiliated with a large eating disorder program but can specialize in that area. There's also, I'm a little hesitant about saying this because some of these are hard to find, but there's some really lovely self-help programs. One is through Australia, through their public health program there, through the government, has a really nice guided self-help program that people can use. Another one that I really like that is actually used in a number of research protocols is a book called Overcoming Binge Eating by Christopher Fairburn, and they just did a revision of it last year, I think it's 2014, and this is another very useful self-help book that I think can be really, really helpful for people with those kind of lingering cognitive patterns. However, we also know from data that working through the book is useful, but it's even better if you're working with a clinician. So even if they're just meeting with someone periodically, we know that can be helpful. But it's such an excellent point, and I think one of our shortcomings as a field is we tend to overvalue remission from behaviors and weight status and health status as defined medically. We need to do a better job of looking at the psychological status, because we know that's the group that's going to be at risk of relapse.
Okay, here's one more. So what are the best assessment for binge eating patients? I assume I may be talking about, is there a standardized assessment?
Oh, there is. I'm hesitant because I could spend another hour on this topic, and I promise you all I won't. This is one of my passions, is assessment, and especially assessing binge eating. So if you go to the Oxford website, it's called CREDO, C-R-E-D-O. It's the Christopher Fairburn's group, and it's the eating disorder program through Oxford has developed several really lovely measures of eating disorder symptoms. And one of the ones we use most is the eating disorder examination, or the EDE. So if you go on that website, there's something called forms or assessment measures. And what they did, this I think was just so generous to the research in the clinical community, is they put them in the public domain. So you can go on there right now, look up CREDO, and then look at forms and publications, and you can find it in there. So the one that we use most in our research setting is the eating disorder examination. And we spend, again, in our research geeky land, we spend hours with people on, how much they ate and was there a loss of control, and then we spend all this time coding it as researchers. As a clinician, if you don't need that level of minutia, there's a really nice questionnaire on there that you can use that asks specifically about the frequency of binge eating, both in terms of amount and loss of control. But clinically, I really like using the eating disorder examination interview, which again is on that website, because it asks a lot of, I think, really elegant questions around what did you eat, how much did you eat, how did you feel as you were eating that. So I'll find in my practice, even though I'm not necessarily doing formal research assessment, that these questions are just really clinically meaningful. And the way the Oxford group developed it was by interviewing patients for years and years and years and trying to get phrasings in ways that feel meaningful to clinically to people. So I would recommend any of the resources on the Oxford website.
And so I see we're out of time. There are a number of other questions, maybe 3 or 4. Would it be okay if I email those?
Please do. Yeah, I'd be happy to respond by email, so
Okay,
I'll look forward
great.
to that. Good.
All
All right, thank you, everyone.